So my talk today is going to be on the current role of interventional radiology in the management of hepatocellular carcinoma. So I'll talk to you about the epidemiology, the risk factors, how HCC is diagnosed, how it is graded, how do you want to evaluate a patient, what treatment options does IR have, and I'll also talk a little bit about surgical treatment options, what does oncology have to offer, and what is the new latest research right now in management of HCC. So if you talk about the epidemiology, then it's the most common primary liver cancer malignancy. It has an incidence of about more than 600,000 cases right now. Most rapidly increasing cancer in the US, and I'll show you a graph where it shows that every other cancer is actually going down, HCC is going up. So you can just imagine that in 2007 there were 19,000 cases and it went to about 30,000 cases in 13. But see this figure, 30,000 cases and 21,000 deaths. So we are not doing that well. More common in men. And for surgeons, what they need to realize is that for resection, the rate of recurrence can be as high as 50% for 2 years. So as you all see in the HPV that, they resect a tumor and that comes back after a year or 2 years with another tumor and they're like, now we need your help. So if they realize that the resection is not a good treatment for HCC, only 12% are eligible for resection or for transplant. And 80 to 90% occurs in cirrhotic livers. So if you know these factors, you can actually tell your surgical colleagues that HCC, if you're resecting HCC, it's not that you're going to treat the patient. So this is a graph. If you see, it's in US 1930-2009, how things have shaped up. This is lung and bronchus, though it's the most common still, but it's coming down. It's on, see the curve. Prostate, colon. And see this. This is the liver. Went down and it's on its upward path now. So everything else is actually has a downward curve except the liver, which has actually become more increasing in prevalence there. So again, they actually in 2013 they came up these facts in Atlanta, the ASCO meeting, where they actually said that there are about 30,000 HCCs and about 21,000 males. 5-year survival was a dismal 15%. 40% diagnosed at early stage with 5-year survival of 28%. So survival decreases to 10 to 3% for patients with regional and distant stages of disease. So you can see that once they have any distant metastasis, then survival really, really goes down. The risk factors, you need to know this. Hep B, Hep C, alcohol, now the big one, NASH. So if you see Asia, NASH is becoming a very, very common thing there. Autoimmune, inherited factors, and aflatoxins. The reason I put Hep B up here and aflatoxins here is these are two conditions in which you will not have a cirrhotic liver. So if you have a normal liver but have a lesion which is typical of HCC by imaging, look back into the patient's chart. Either he could be Hep B or he could be a conformer. So aflatoxins. So remember this. So aflatoxins and Hep B will actually give you a HCC in the lesion in a non-cirrhotic liver. Hep C, alcohol, NASH, everything else will cause you a cirrhotic liver. Hep C, just a word about Hep C. There are about 3.2 million Americans chronically infected with Hep C. Why? Because all these patients got infected in the 60s and 70s when Hep C was not diagnosed. They used to call it non-A, non-B. Nobody knew about Hep C. So if you go and see the veteran population of the VA, pretty much every second patient of the VA has Hep C. And every Hep C patient in his future is going to develop HCC someday. Hep B, about 800K to 1.4 million Americans chronically infected. So if you go to Asia, Hep B is the most common cause of HCC. If you come to America, Hep C is the most common cause of HCC. That is why if you would look into the literature, they behave differently, their treatments are a little different. Then comes alcohol, and then comes this big thing, NASH, which is now becoming the most important cause of HCC. So just a word about NASH, why you need to know about NASH. 9 to 30% of Japanese adults have NAFLD, and NASH is estimated to be 1 to 3%. So it causes cirrhosis in 5 to 25% during a 7-year follow-up, and a 5-year rate of HCC in NASH is 11.3. So this is really prevalent, NASH, and now that is going to be the most common cause of HCC. Why do you need to etiology? Because the liver transplant is also very important. So when you have a liver transplant, you won't need to know why this patient has HCC, because every etiology of HCC has a different prognosis on liver transplant. So this is the UNOS data. So UNOS is the organization which controls all the transplants across America. So they saw from 1994 to 2009, they did 54,700 transplants. Liver transplant for NASH and HCC are increasing. There was a significantly worse 5-year graft survival for HCV than for NASH. So then HCV is actually the worst among all the performers. If you do a liver transplant for HCV, then it is a worse prognosis. So as for liver transplant centers, you need to also know that liver transplant centers in US have been defined. There are centers which will do Hep C patients. There are centers which will do HIV patients. And there are centers which will do everything, but some centers are designated for them. So how do you diagnose HCC? This is very important because we do not want to biopsy any HCC lesions. So as per the American Academy Association of Liver Disease, if you see a liver nodule less than 1 centimeter, all you need to do is follow up. This is still the guidelines, but you can actually push your limits. You can get a MR, especially a EOS MR, and say that yes, it is HCC. But less than 1 centimeter, the guidelines still say repeat ultrasound at 3 months. If it's stable, then you just repeat it. If it's growing, and then you go to size. More than 1 centimeter, what you need is a good triple phase or a 4-phase multi-titer CT or a dynamic contrast enhanced MR. Half the time the problem is that a study is not good or it is just one phase, so we really cannot diagnose HCC. So how should be? It should be arterial hypervascularity with a venous or a delayed phase washout. This is the most important thing. If you have any lesion in the liver which is arterially enhancing and has a delayed washout, you can label it at HCC. You do not need a AFP. You do not need a biopsy. If you have a cirrhotic liver, it supports your diagnosis. If you don't have this, you still don't want to biopsy. You want to see that the study was good, or you want to order a second study. You can get an MRI done. If that solves the purpose, it's good. If does not, then you might need to do biopsy. This biopsy is normally more important if you have fibrolamellar cancer. That is the time when you kind of are not sure, it's a non-cirrhotic liver, it's a young patient, then you might need to biopsy. Why you don't want to biopsy? Because of the risk of seeding. Again, so what it is coming for the liver transplant data. So when they looked at the liver transplants, about 5% of the liver transplants actually developed mets and seeding because of the biopsy. And for 5% patients who actually had it's a big number for liver transplant patients. They do not want you to biopsy any lesion which you can diagnose by imaging. So these are the AAST guidelines, but the transplant is controlled by these people. UNOS. I showed you a slide there. UNOS. They control the transplant. So they have their own guidelines. So they have one more thing in this guideline. They say it should also have a capsule. So if you have a hypervascular capsule, then for transplant purpose, that is HCC. So remember, that is the UNOS criteria, has the ASLD criteria plus capsule. It's a pseudo capsule HCC, it's not a true capsule. Whenever you want to see these patients, you always want to see the ECOG performance status. This is not only for HCC, it is for any cancer patient. You want to give them a ECOG criteria because everything on treatment depends on the prognosis, how the patient is doing clinically, then you can treat him. So 0 means patient is fully active, can do all activities of life without restriction, is able to work. 1, restricted in physical strenuous activity but ambulatory and able to carry out work or a light or sedentary nature, light work at home. 2, if up and about for more than 50% of the walking hours. 3, 4, 5, no role of IR in 3, 4, 5. The reason being, you will not make a patient who's lying in bed more than 50% of the time any better. His prognosis is already bad. So always when you see these patients, you want to give them a ECOG status. What is their ECOG grade? You always want to see the Child-Pugh score, the CBS score. The Child-Pugh score includes bilirubin, INR, albumin, ascites, encephalopathy. Has points for it. You total these points. You don't want to remember this? Just go online, Google it, Child-Pugh calculator. There are tons of calculator. Put in the values. You will get a 5 or 6 for a child A, 7 or 9 child B, and 10 or 15 for child C. So a lot of people will just write child A, B, C. No, you need to write A5, B7, B9, because B7 has a different prognosis from a B9. Surgeons, once it touches like B9 or B8, will not touch the patient. They will refer it to you. This is the most important slide. This is the BCLC staging. So this is how treatment is planned in the world today itself. It's old. It's 2003 and 4 on Lancet. This is from the Barcelona Clinic of Liver Disease, where they said you have diagnosed a HCC, stage 0, this is performance status, the ECOG status 0, child PUA. Very early stage, single less than 2 centimeters, carcinoma in C2, single. See here, portal pressure and bilirubin. I keep telling my surgeons, why don't you want to measure portal pressure? They don't want to measure portal pressure. Why? Because half the patients they operate will become non-operable. So you actually supposed to measure portal pressure. If the portal pressures are high, he's not a candidate for resection. He's not a candidate for transplant. And that is where the prognosis of the patient changes. If it's normal, you do resection. If it's increased and you have vascular disease, no, then goes to liver transplant. If yes, then this is percutaneous ethanol injection or RF. So these are the curative treatments. Why? Because liver transplant is the best treatment. They consider resection also under curative. Everything else after this here is all kind of control, palliative control. Okay. This is stage A to C, Ahuja. So then you have Ahuja classification and you can have the CLIP classification. I have not included in this talk, but if you go online, you can just, these are just classification based on imaging. So depending on the size of the tumor, it is multifocal, is it bilobar, amount of volume it involves, and the status of the portal vein involvement. So you can have Ahuja 1 to 2, performance status 0 to 2, child PUA and B, early stage, intermediate, advanced, and then you go ahead, these come here, these go to chemoembolization. If you have advanced disease which portal vein invasion, then you cannot do chemoembolization. Then you have newer agents, and then you have this is the survival, 3-year survival of 20 to 40%. So you can see what happens. So once the patient advances from stage 0 to A, C, and D, the survival goes down. 5 year is 50 to 70%, goes down to 20 to 40%. 1 year to 10 to 20%. So remember this, everything depends on staging. So whenever you see a patient of HCC in clinic, you want to stage him, you want to tell him his prognosis. Nobody might have told him that his life is just a year. So you need to tell him about all this. This is the new classification which is coming up. So people were not happy with this classification because there were a lot of patients who could be treated, but we are pushing them here in this stage. Liver transplant surgeons are not happy because they could do liver transplant on some of these patients here. And the other big thing in this classification is you do not see any radioembolization anywhere in this chart. So in Asia, they came up with this Hong Kong liver cancer staging system, which is becoming more and more prevalent. The only problem with this is that these patients are predominantly Hep B. They're HCC, but they're Hep B HCC, not Hep C HCC. So what they did was they collected data on 2026 variables from close to about 4,000 patients between 95 and 2000, and they did Cox regression studies and they did the CART classification and randomly located in training sets and tests. So they came up with this classification system which actually tells you better about the prognosis. So if you can place the patient in this chart, you can pinpoint him what prognosis he has and what treatment is going to be best for him. Something to note here is there is still no yttrium-90 in this chart, because this is older patients here. So it's here what they did: ECOG 0 to 1, child A and B; ECOG 0 to 2, child C. Pretty much everything looks similar except you have liver transplant here. See, ECOG 2 to 4 means performance status is bad, child C, but it's early tumor and there is no extra vascular involvement or metastasis. Stage 4A goes to liver transplant. So they realized that even if the late patients can get an early liver transplant, they had better prognosis and survival. So this is the main thing that has changed in this Hong Kong classification. So the Hong Kong classification has significantly better ability than the BCLC system to distinguish between patients with specific overall survival times. And then it also identifies subset of BCLC intermediate and advanced stage patients for more aggressive treatments than what was recommended by the earlier BCLC system. What actually is the natural history for the disease, any chronic liver disease? So you have chronic liver disease. When do you call it then it's compensated cirrhosis. You have cirrhosis, but patient is doing okay. They stay in this area for years. This is the problem when they decompensate. What does decompensation means? They have ascites, they can have variceal hemorrhage, they can have encephalopathy and jaundice. Once any of these occur and they decompensate, then the progression to death is very fast. Here, see this chart. So this is all patients with cirrhosis, median survival 9 years. Once they decompensate, median survival is 1.6 years. So the main thing is whether the patient has any of the complications of cirrhosis. That changes the survival. This is nothing to do with HCC. I'm just talking about cirrhosis. So if a patient who is already has developed these complications and has HCC on top, his prognosis is going to be much worse than a patient who has a hepatocellular carcinoma but his liver is still well compensated. So again, this is the same thing what they've taken is the ASLD guidelines. They've taken it from the same treatment as the BCLC, where they have resection, liver transplant, RFA, TACE. This is sorafenib, this is the medical treatment, and then symptomatic treatment. Palliative treatments, curative treatments. So what is the goal of treatment? What do we want to achieve? So one is curative, which is the best. What IR can offer? So IR can bridge the patient to transplant. Bridge to transplant means patient is a transplant patient today, but he has to get his evaluation done. He has to wait for a liver to be available for transplant. Because he has to wait during this period, his liver disease can decompensate, his tumor can grow to a size which is outside the UCSF or the Milan criteria. So pretty much everybody follows the Milan criteria, except transplant surgeons have the discrepancy that if they feel the patient is healthy, they can follow the UCSF criteria, where so Milan criteria gives you one tumor up to 5 centimeters or 3 less than 3. The UCSF criteria is a little more less stringent. It lets you do till a tumor of 6.5. Downstage to transplant means you have a tumor, a patient who actually is not a transplant candidate. You treat him with local regional therapies. His tumor shrinks in size and he becomes a transplant candidate. That is downstage to transplant. If for some reason the patient is not able to get a transplant, you can downstage to resection. Make a non-resectable patient resectable. And also neoadjuvant treatment in combination with ablation. So you can combine treatments. So when you combine two treatments, they've shown, I'll show you some slides where they've shown it to be more effective. And then everything else is palliative. You're just trying to control the disease. If it's multifocal disease, bulky disease, limited extravascular disease, and vascular invasion. So this is a curative intent, this is a palliative intent. What all can we offer? So we have variety of systems. We have transarterial embolization, which just means bland embolization. You just embolize with particles, PVA particles. Transarterial chemoembolization, where you give chemotherapy and then you embolize. And then you have TACE with drug-eluting beads, known as DEB TACE, where you actually soak the beads, which take up the chemotherapy, and then you embolize with them. The next is transarterial radioembolization, which is where you use radioactive particles for tumor treatment. People didn't like this word because it is known as radioembolization, but you're not embolizing, you're using really small particles. So now they call it SIRT, selective internal radiation therapy. You just deliver particles, radioactive particles will stay in the tumor and deliver radiotherapy from there. And then you have percutaneous ablation techniques. We're going to discuss all of them. So why are we able to treat any tumor in the liver, especially HCC, through the arterial route? The reason being, liver again has, we all know, dual supply. Hepatic artery 20-30%, portal vein 70-80%. So even if you knock off the hepatic artery and you have a patent portal vein, the liver does okay. So when you realize this, you can actually, and the tumors are all, especially HCC, it is hypervascular, right? It is supplied selectively by the hepatic artery. It has got nothing to do with the portal vein. So if you can embolize and stop the blood supply to the tumor with the hepatic arteries embolized, the portal vein is patent, liver does fine, liver functions done okay, and you can actually control the tumor you can embolize the tumor. But what I said, you have to have a portal vein has to be patent. So here the capillaries are 5 to 10 micrometers and the arterioles are 10 to 20. So you need to realize at what level we want to cause the embolization, because all these techniques will cause embolization at different levels. There are different level of particles. So this is the arterial supply to hepatic tumor. This is the celiac, okay? Celiac. This is the, what's this? What artery is this, Hussain? If patient has such a big left gastric artery, just think about it. Just think. It's the same artery, it's curving. What artery curves like this? It's the splenic. So this is this catheter, this is the celiac, right? The catheter is here. This is celiac. This is probably the left gastric, the small one. This big thing is the splenic. This is the, what's this? Where's my arrow right now? Common hepatic. What is this? What's this? What's this?
This is the left.
Okay. This is the right. So you see right, you can see these branches, the whole tumor is supplied, and you see the tumor in the arterial phase. Why? It's a hypervascular, it's an arterially supplied tumor. You can get your microcatheter into these branches and you can see the whole tumor is being supplied from here. Okay. Why, how this concept about transarterial chemoembolization came in? So you need to know these two papers, Lovelet in Lancet and Lowe in Hepatology in 2002. So what Lovelet did, he compared, these are both randomized controlled trials. These are the starting points of where transarterial chemoembolization and TACE, everything started. There were two arms, transarterial embolization compared to transarterial chemoembolization. Means patients with SCC treated with just bland embolization without chemotherapy, and these are patients with chemotherapy. A mean of 3 treatments. So this is the patient with chemo, this is the control. This is the time since randomization. So you have it's a p-value of this meta survival, 0.009. Here, it was again a randomized control, Asians, these are Caucasians here. There were two arms, TACE, transarterial chemoembolization, and this is just symptomatic. This is chemoembolization to transarterial embolization, bland versus chemo. This is transarterial chemoembolization versus just symptomatic treatment. Again, showing that there is marked difference of survival in the chemoembolization group. So how do you select your patient for TACE? So BCLC-B or A, ECOG 0 to 2, do not want to treat a ECOG 3 patient. Bilirubin less than 3, no biliary obstruction. Can anybody tell me why I'm worried for bilirubin and no biliary obstruction? What am I embolizing?
The artery which supplies the biliary.
Yes, the artery supplies the biliary system. So if I'm blocking the artery and the patient already has dilated ducts, I'm going to make it worse. These patients don't do well. So actually you can treat them now they treat them till bilirubin of 7 or 8. They treat them in centers where they have transplant patients. So patient has been evaluated by transplant. It's a transplant center. In case the patient goes into liver failure, they will do an urgent transplant for him. So we can't do it here. But if you go to UCSF, they are okay treating patients till 7 of bilirubin. But standard is 3 of bilirubin, no biliary obstruction, creatinine less than 2 because you want to use contrast, no extrahepatic disease, no vascular invasion, no hepatofugal flow. Why hepatofugal flow? What does hepatofugal flow denote? Yeah, so if it's a hepatofugal flow, means the blood is going away from the portal vein, right? So the portal flow is less towards the liver. So now you knock off the arterial supply, portal flow is already less, you're going to cause necrosis, you're going to cause an abscess, you're going to cause trouble. So you always when you do a celiac run or a SMA run, you wait till you see the portal system, it's patent. There's no clot, and then you see the portal blood going to the liver. No systemic infection, encephalopathy. Encephalopathy can get worse. So pre-treatment imaging, why do you need that? You need to know where the tumors are. Classic and variant arterial anatomy. We also need to know why if you have accessory left or accessory right, not only the surgeons. We need to know it before we go and do any angiogram there. Status of the hepatic veins, portal veins, bile ducts, ascites, extrahepatic disease. So the same way as surgeons, we divide into coronary segments. We know where exactly the tumor lies. Every segment has a specific supply. We sometimes do not see the tumor. We can target that vessel and we can find where the tumor is. This is the traditional TACE protocol, how it's done. You use lipidol, that's poppy seed oil. You can mix it with chemo, doxorubicin. In US, we use about 50 to 150. I use 50. People in Colorado use 100. They've had some problem using 100. Patients develop alopecia, fall of hair. You don't want that to your patients. So if you go to Asia, they use a triple duct. They use cisplatin with doxorubicin. In US, we don't have it available. So it localizes in tumor, variable time course, perfuses through the non-tumoral parenchyma within 7 days. So what lipidol does, it is a carrying agent. It mixes with them, forms an emulsion, sticks to the tumor and slowly releases the chemo. Transsinusoidal penetration. The lipidol also penetrates through the transsinusoids into the portal site system and blocks the supply there. And then you can always additionally embolize back in the back with the gel foam or particles. So the traditional TACE is actually with gel foam and particles, but now what they're doing is they're moving it, they're not putting any gel foam or particles in the back so that they can go and retreat the patient. The concept of retreating the TACE patient. This is the water in oil emulsion. So this is the oil and this is the chemo. So chemo is 6 to 7 ml. You take at least 6 to 7 ml or more of the oil, mix it, form a solution, and you deliver. It's also helpful. Why? Because it stains the tumor. It is one of the agents which was used in the past to diagnose HCC. So days you didn't have a CT scan, you could use Lipiodol to diagnose HCC. What are the adverse effects of TACE? You have a post-embolization syndrome. Pretty much everybody has this. Fatigue, fever, malaise, abdominal pain, nausea. This is not only for TACE, any embolization. You do a UAE, you do a splenic embolization. They tend to have fatigue, fever, and malaise. It is more with this because you're giving chemo. So the fever, pain goes away, the fatigue comes in, stays there for a week. They can have a biliary injury because I told you supplies from there. They can have an abscess. If they've had a biliary intervention in the past, if they have a biliary stent, then they need a bowel prep. They need more antibiotics because the biliary stent presence there can give ascending infection from the bowel. Enteric ulceration. You can have supply. You can have a lot of aberrant supply coming from the hepatics, going to GDAs, going to right gastric, going to colon. Vascular injury, chemovasculitis, tumor rupture, rare. So always remember, the middle colic can actually sometimes arise from, middle colic is a branch of what? What does it come from normally? SMA. Middle colic can come from the celiac. So if middle colic is coming from the celiac and you didn't realize it and you embolize there, you send all the particles and you send everything to the colon, you're going to have an enteric ulceration, bowel perforation. So this is TACE with the large HCC. This is a big HCC, this is MR. It's see hypervascularity. This is post-embolization. You can see that there is no more vascularity there. It has been done with Lipiodol. You see the Lipiodol there. So why Lipiodol helps us is a couple of things. If I was getting only part of the tumor here, like a crescent sign, I realize there is one more supply to the tumor from somewhere else which I'm missing. This big tumor with this is going to be very helpful for me to do a RFA. So if a tumor is more than 3 centimeters, a single modality of treatment does not cover the tumor very well. You probably are going to get 80-90% of the cells dead, but you still have 10-20% cells which survive. And always the recurrence happens on the periphery. So if you read a lot of post-treatment scans, which these patients will have, always look at the periphery for enhancement. If the periphery is enhancing, that is where the recurrence for HCC occurs. So now coming to additional outcomes, how the outcomes have been recently. So this is the group from Northwestern. So they did 172 patient cohort retrospectively. Median survival BCLC-C was 40 months, A. B was 17.4 and C was 6.3. So what really makes a difference is what is their child, what is their status in the initial. If they were clinically doing well, they do well. Otherwise, they don't do well. This is from Japan in the hepatology where they did close to 5,000 patients, median survival of 40 months. This is just with transarterial chemoembolization. So this is Lipiodol TACE CT. Why does it help? This was the MR, which was read this lesion as HCC. So we went in to do the angio to realize we don't see that lesion anywhere. What we saw was this lesion. Here. We don't see that lesion anywhere. You don't see that lesion anywhere. So actually the lesion HCC was here, was not here. This was just a hypervascular lesion there, incidental finding there. Why you can use it for RFA? Small lesion, you can 1.6 and 4 centimeter might not be able to target it very well with ultrasound. You might not be able to see it. You can do a Lipiodol chemoembolization, stain it well. You see this very well under ultrasound. Get your RFA probe here, and you can do a RFA of this lesion. So mechanism of action, I was telling you where exactly these different techniques work. So this is the arterial flow. It divides into smaller branches, arterioles, and then it goes to the sinusoids. So the bland embolization actually works at this level. Conventional TACE works at this level. Depth TACE, drug-eluting beads, where you use smaller beads, works same level as the bland embo. Why 90? Why don't we call it embolization anymore? Because these particles are really small. These are 20 to 30 micron particles. So they actually percolate across, all the way across here, and they stay here in the tumor. They do not cause any embolization. So why comparing TACE versus transarterial embolization? This is just bland embolization. So if you talk to anybody from Sloan Kettering, they have a total different view of oncology treatment there. They will still treat patients with ports. Ports not means here. They put a vascular port here. So if I don't know if you've seen on any of the patients where all this started was, surgeons would go in, would actually surgically ligate the GDA, put in a port into the hepatic artery where the tumor is, and then through the port they would give chemo. continuous chemo to that patient. So that is the initiation of the chemoembolization for tumors. So they still do that. The other thing that Sloan Kettering group doesn't believe is they don't believe that transarterial chemoembolization, where you're using chemoembolic stuff, is any better than just doing a transarterial embolization. They feel all the effect is just because you're taking the blood supply off. There is no role of chemo. So this is the study from them. So this is a study from Brooks and Hepatology in 98, where he treated 80 patients, transarterial embolization with low probability of tumor progression, 77 to 55. No difference over survival at 2 to 4 years. Then Lovelet was the same person who we compared, we showed the study, we compared transarterial chemoembolization to just bland embolization. So here, the transarterial chemoembolization, median survival was 28.7, and for bland was 25.3, and symptomatic treatment was only 17.9. So TACE responders, 96%, 77 and 47, survival 1 to 3 years. So TACE had much better response than just transarterial embolization. This is coming from Sloan Kettering, where they did 322 patients, 776 embolizations, they used smaller particles, and the survival looks pretty good. See this 96, 77, 47, 84, 66, 51. So everybody thought it's pretty much the same. So chemo has no role. But when people really looked into that paper, they realized, see this, they had a 11.9% complication rate and a 2.5% death. So when you have 11.9, which is like 12% complication rate, so the complications rate was much higher when they were doing just bland embolization, means just taking the arterial supply off, not giving any chemotherapy. So everybody else in the world does not still believe it. Sloan Kettering still does it. So if you find they're one of their attendees, you see one of their conferences, they will actually really fight that we still do this. They have huge numbers, they're a big center, it's just their belief. Coming to the next modality, which is DEB TACE. This is drug-eluting bead TACE. So how this all concept happened was, you need a way so that the chemo can stay in the tumor. So with lipidol stays for a week. So here what we're doing is we're using microspheres 100 to 500 micron. So initially we're using 3 to 500, now we're using 100 to 300. Some places have gone to M75, which is 75 micron. This is the ion exchange loading slow elution method. So basically these beads go to the pharmacy, they soak them with chemo for about 2 hours. They soak the chemo on the surface and then slowly release the chemo in the next month or so. So lower peak plasma levels of chemo. So what happens is, when you soak the chemo in these beads, the beads slowly release the chemo. Patients have less side effects from the chemo. There is no increase in the blood level of chemotherapy immediately after treatment. These are how these beads look like. This is if you once they perfuse. So they embolize the peritumoral arterioles. This is where they work. These are the beads. You can see them. So there are 2 companies which make these beads, LC beads and Quadrospheres. So for some reason the LC beads outside US are known as DC beads. So if you ever go to a European conference, you'll hear DC beads and you've never heard them here. It's the same thing. In US they call them LC beads. In Europe they call them DC beads. So they can be used for doxorubicin or irinotecan eluting. Doxorubicin for HCC, irinotecan for colorectal. They're made by BTG. Quadrospheres or HepSpheres outside US, they are only for doxorubicin. You cannot use irinotecan, and they're from Biospheres Merit. These are how they look. This is how you mix. So the one I showed you earlier was the oil and the chemo. So this is the particles. This is the particles. They come loaded with soaked with the chemo from the pharmacy. You mixing it with saline and with contrast so that you can see them when you inject them. Patient selection, similar to TACE. Ideal anatomy to deliver beads via single feeding artery rather than a lobar treatment. With the doxorubicin lipidol, you can actually do a lobar treatment because the lipidol is going to stick to HCC. It has the affinity that it goes all the way to HCC. So it is a way that you can target it. Here you cannot target it. So if you want to do a lobar treatment, you would clean up all the vessels. You don't want. You want to have anatomy where the tumor is supplied by 1 or 2 vessels and you can actually reach those arteries. Does not stain the tumor. So you can not use it for XRT or RFA. XRT is outside SBRT. It's radiation. So I'll show you some slides how radiation is done in liver. And if you're planning to use for post-procedure diagnosis. So other thing they use lipidol also is for diagnosis. Sometimes you're doing an angiogram and what happens is you realize patient was labeled as 3 tumors. When you do the angiogram, you start seeing 4 or 5 areas of enhancement, or you give lipidol, other areas pick up, and then you go back to your CT and MR and you see those lesions there. It changes prognosis because patient changes from a transplant to a non-transplant patient. Adverse effects similar to TACE, but they're lower in frequency because there is slow release of the chemo. They have less pain, less side effects as nausea and everything. So this is the known as you'll see a lot of people when they will talk about DEP-TACE trial, they talk about the Precision 5 trial. This is in CVIR from Europe. So there's 2012 patients randomized controlled to TACE compared to DEP-TACE. So there was no statistically significant difference in response rate. So response rate was the same, but improved outcome in child B patients. If the patients are sicker, the tumors are bigger, beads do better than just bland embolization. This is another paper in CVIR 2012 where they compared, they had 173 retrospective study in DEP-TACE, median survival was like 43 months. So this is coming from that paper. This all is coming from the Lama paper, Precision 5. So overall 6-month tumor response rates. This is DC beads, this is conventional TACE. So response rates is much better in DC beads, but this does not achieve a statistical significance. This is a response in more advanced patients. So if you subgroup analysis in more advanced patients, child B, this was a statistically significant difference. ECOG 1, bilobar and recurrent disease. Where it was really significant was doxorubicin related side effects. So when you have beads, the side effects are really low as compared to the conventional TACE. But again, these studies are biased. These were done with 300 to 500 beads, which you do not use today. So now, this is even lower. So when do I use DEP beads? Routine is becoming popular in the US actually. Pretty much 80% of the sites will only use DEP-TACE. You use it for larger tumors where you want more embolic effect. You use it for exophytic tumors because risk of rupture. So remember, I've been telling on imaging that HCC is one tumor which is on the surface can rupture. It can present as emergency. It can present as hemoperitoneum. Surgeon needs to go in sometimes. So these are exophytic tumors. So you worry for rupture and they rupture after treatment. So if you worry for rupture, then use these beads because they are more embolic. For TACE, non-responders. You've already done a TACE, patient did not respond, so now you use beads. Here, you see this. TACE to segment 4 lesion. You see a good stain, very good stain post CT, lipidol all there, comes back after a month follow-up. This is all washed out. It is still enhancing on the arterial phase, not responding. So this patient then needs a DEP-TACE. It's responded here. Safety and effectiveness of DEP-TACE for advanced. So I told you it is better for advanced stage. So now there was a paper here. This is from Kalwa, from Mass General, when they saw 80 patients of advanced HCC treated with DEP-TACE. Median performance patient-free survival was 5.1 months. Overall survival was 13.3 months. ECOG performance status less than 1, better than overall survival was this. So overall, they said that DEP-TACE is actually safe and effective, and you can easily treat patients with performance status between 1 and 2 with DEP-TACE. Coming to radioembolization, known as SIRT. So people don't want to call it radioembolization because it's not embolic. So they want to call it SIRT, or known as Y90. So you basically have two, again like two beads, we have two products here, the TheraSpheres and SirSpheres. The difference being, TheraSphere is glass. It's 30 micron particle. Y90 is inside of the glass beads. They are glass, they are heavy, more specific gravity. The SirSpheres, the resin, it's a resin microsphere, same size. Y90 is coated on the outer surface. So because Y90 is the outer surface, they have less, they lighter in weight, less specific gravity, lower dose / bead than TheraSpheres. So remember one thing, you have to give the same amount of radioactive dose. So if the beads are less, if the dose per bead is less, the beads are going to be more. So if you have the same dose of TheraSphere to give, you will have less beads. If you have the same dose of SirSphere to give, you will have 50 times more number of beads. It makes significance because you worry for reflux, you worry for non-target embolization, you worry for GI embolization. So in those cases, TheraSphere is much safer than SirSpheres because less embolic load. So low embolic load and volume. TheraSpheres used to be owned by a company, a different company, but now it's bought by BTG London. It is made actually in Canada. They are glass, 20-30 microns. Yttrium-90 is the integral component of the glass. So each vial contains about 1.2 to 8 million microspheres depending on the dose. So this comes specific for a patient. TheraSphere vial will come specific for a patient, means you have to know which day you are treating the patient. The vial is specially prepared for that specific patient for that specific time. So you do not, the vial comes ready for the patient. While in SirSpheres, it comes as a standard vial. In nuclear medicine, the tech draws the amount of activity we want from there. Activity per sphere is about 25,000 becquerel. So this is not FDA approved. This is a human drug exempt device and used at a particular site required by IRB. SirSpheres. So resin 20 to 60 micron, yttrium on the surface has 40 to 80 million microns. See, this comes standard 3 becquerel, 3 gigabecquerel. So every vial will have a 3 becquerel. Here it varies 3 to 20 depending on how much you calculate for the dose. Activity per sphere is only 50. Activity per sphere is 2,500. So those particles are 50 times more radioactive than these particles. This is FDA approved for colorectal, but we use it in HCC, we use it everywhere else. Y90 patient selection. So these are the big guns. So you need to be very careful while selecting patients here. P-bili less than 2. You do not want to treat any patient who has a bili of less after more than 2 because those patients do not do well. They develop liver disease. They basically develop radiation induced liver disease, REILD, and they die within a couple of months. You may include more advanced cases. When you're treating patients with yttrium-90, you do not worry for vascular invasion. You do not worry for main portal vein involvement. Why? Because this is not embolic. This is smaller particles. It works at the levels of the arterioportal shunting. It does not work at the level of the arterioles. So you're not embolizing anything. As you're not embolizing, you're not worried whether the portal vein is patent or not, there is a portal tumor or not. And you can also use it for infiltrative tumor. So this is how a yttrium-90 actually works. Consultation, tumor board, everybody sees them. Medical oncology, surgical oncology, nuclear medicine, radiation oncology, interventional oncology. Consensus for Y90 treatment. In 1 to 2 weeks, you do a pre-treatment screening evaluation. Check labs. Bilirubin is okay. AST/LT okay. Nothing has changed in the alk-phos. Tumor mapping. Tumor mapping means you get a CT and MRI, complementary studies to see, or octoscopy for this is for neuroendocrine, this is for all Y90s, not for HCC. So you need to have some imaging, need to anatomy, where the lesions are, how many lesions are there, liver predominant disease, team reviews, and then you plan for treatment. How do you plan? You do a pre-planning. So this pre-planning is, you do imaging, you planning tumor volume, optimal catheter placement for radioembolization, you close off all the vessels that can take these radioactive particles to anywhere else other than the liver, you give the MAA, patient gets a scan, and you calculate the volume. This is this, hepatic angiogram, protective embolization, MAA. Once all this is done, you realize that the patient safe to treat the patient, safe delivery achievable. Then in next 1 week, you actually treat the patient with Y90. You just place the catheter at the same place you gave MA and you treat the patient. And then you can do a gamma scan, you can actually do, some people are doing PET scans post-procedure. So this is this, see this huge tumor, the dome tumor, 7-8 centimeter tumor. See the arterial supply, it's very well supplied by the artery here. You can get a microcatheter here, you can selectively treat this tumor. This is a non-transplant patient. This is another patient, how Y90 looks post-treatment. See, this was the left lobe treatment. So the whole left lobe is highlighting, the right lobe is okay. Caution with Y90. You need to know about arteriovenous shunting, especially with HCC. HCC is known to cause arterioportal shunting. You see this? It's a celiac, it's a replaced right coming from the SMA. Okay? This is the whole tumor. And what is this? This is the portal system. So always we look out for a portal system. You have this big of shunting. We tried for a Y90 MA. His lung function was, it has to be less than 20%. This is 95%. Everything goes to the lung. You cannot treat this patient with Y90. HCC with portal vein thrombus. You see this? It's invading the portal vein, invading the portal vein, invading the portal vein. This is post-treatment. Tumor has shrunk. Portal vein is patent. It's decreasing tumor. You can easily treat this with HCC. The worry here is you would prefer SirSpheres than SirSpheres. Y90 adverse effects. Why Y90 is good? Adverse effects are very low. This is a day procedure. You do not keep the patient in-house. Patient gets the procedure and goes home. Pretty much has no side effects. Fatigue. This is the only predominant sequelae. It's much less than with chemoembolization. Non-target worry is non-target embolization. So your procedure is more technically demanding, because if you do a non-target embolization, you can have cholecystitis, you can have GI ulcers, which can have bad outcomes. You can have hepatic fibrosis, you don't calculate the dose correctly. You can have radiation-induced liver disease, and you can have radiation-induced lung disease if you do not correct the lung shunt properly. So if you really see the side effects, constitutional symptoms, fever, malaise, most common in 60%, nausea in only 10 to 20%, abdominal pain in 10 to 20%, fever less than 5%. So if you see quality of life, Y90 is the best treatment for quality of life. But you can have arterial complications, but these are all procedure related. Liver failure, 0.9 to 4%. So what is REILD? This is a topic you'll hear a lot. Radioembolization Induced Liver Disease. So what is the data coming from? Years ago, they tried to treat liver tumors by external beam radiation, and patients did not do well. They went into liver failures, had high bilirubin, developed ascites. A similar concept happens if you treat these livers with radioembolization, especially if they've had prior chemo. So RELD as defined as they have total bilirubin of more than 3. Bilirubin starts worsening. Ascites, clinical or imaging, appearing in 1 to 2 months after radioembolization in the absence of tumor progression or bile duct occlusion. So there is no tumor progression, there is no bile duct occlusion, but the bilirubin goes up and patient develops ascites, also known as anictic ascites. So Y90 outcomes. So we need to have some outcomes to tell people that how we are doing. So this is the great group from Northwestern. So they compared 291 patients, single center study, time to progression 7.9 months, overall survival for, this is for the child PUA, 17.2 months, B was 7.7 months. So remember, these patients, you're using these patients, these are for big guns. These is for a tumor 7 centimeter, 8 centimeter, portal vein invasion. So already these patients are sicker patients. This is another multi-center study from, this is from Europe, Sangro in hepatology. And then Salim again, the same group, Salem again came up with 2011, where they compared Y90 to TACE. So they had 123 group patients in Y90, 122 in TACE. So the overall survival, better, 20.5 compared to 17.4, but it was not significant. But overall 7 BCLC-B, again was pretty much same. Time to progression was significant. So basically, you want to choose your patients very well. The where it really helps you, benefit to those awaiting transplant. So patients who are awaiting transplant, means bridging to transplant, Y90 is really good. Patients you want to downstage to transplant, it's really good. That is where it comes in. So radioembolization, chemoembolization didn't have much of a difference here. So this is the Y90 large series reporting survival outcomes in intermittent stage disease, where they have all these groups. The Salem, Sagro, and this is another group, where they compared all these patients, and then they published hepatology, where they showed the overall survival. Pretty much everybody had the same overall survival, with median overall survival, except for this in child B. So child B always survival goes down. So where is Y90? Downstaging to transplant. This is important. So remember, we talk a lot about downstaging. How much it happens is 15%. 10 to 15% tumors you are able to downstage. But even if you are able to downstage 10 to 15% patients and they get a transplant, it's a big number. So 86 patients, they looked at, this is again coming from Northwestern, looked at the UNOS T3 disease, mean tumor diameter 5.7. So they are not transplant candidates. So this is mean. 43 TACE, 43 Y90. Response, 61% against 37. This 61 is Y90. 37 is TACE. So clear benefit. Downstaging 58 to 31. Time to progression 33 to 18 months. Event-free survival 18 to 7 months. Overall survival 36 to 9 months. So it's clear benefit for Y90 for these big tumors. Coming to percutaneous liver directed therapy. So I spoke all about the arterial therapies. We have percutaneous therapies where it comes all from the surgical history. So what you can do is thermal ablations. You can have RFA where you heat, or a microwave also is heating. You can do cryoablation where it's freezing. You can have a percutaneous chemical ablation where it's ethanol injection, or you can inject acetic acid, the older treatments, or the new person here is the percutaneous membrane disruption, or the IRE, irreversible electroporation. This is very good for pancreas. So I'll just touch base on RFA, just let you know about one method. I don't want to get into details to everything. This is the method which has the maximum amount of literature on. So RFA is basically, it generates energy with alternating current, delivers energy, closed loop between radiofrequency generator and needle electrode. So you place RFA probe, you place electrode up here, you have a generator, you send electricity, generate heat, causes friction, ionic movements. When the temperature reaches 60 degrees, you start having necrosis. But we normally go to 110 degrees, but 60 degrees, you start having necrosis. This is like a Rita RFA probe, this is another probe, this is the cancer treatment. Patient selection. So like if anybody you want to biopsy, where you put in an 18 gauge or a 20 gauge needle, you want the INR less than 1.5, platelets more than 50. RFA is a 14 gauge or a 13 gauge needle. Sometimes you want a 12 gauge needle, so it's a big needle. So you want INR less than 1.5, platelets more than 50, single lesion less than 5. Why? Because when you burn these lesions, you want a 1 centimeter of normal margin. You want to burn 1 centimeter more. So 5 centimeter lesion means you have to burn an area of 7 centimeters. So our RFAs were not that good at that time. And the other problem is that when you need these big areas, you need overlapping zones, or 3 lesions less than 3. Increase this with lesion less adjacent to the gallbladder. You need to protect the gallbladder, bowel, and central biliary tract. What bowel is very close? Always to liver. There are 2 bowels which are very close to the liver.
Hepatic flexure.
Yes. Why you worry for the duodenum? It's closed. It's not mobile. It's not mobile much. It doesn't move much. It's very less space there. And the colon is a retroperitoneal, right? So it's not the transverse. It's the ascending. That's it. Yeah. So ECOG 0 to 1, child A to B, outcomes correlated with lesion size. Larger lesions, higher likelihood of micrometastasis. So they realized that when they were treating lesions more than 3 centimeters, they would have recurrent disease. So you need a 1 centimeter margin around it. So like a 2 centimeter tumor needs 4 centimeter. And the RFA has a problem of heat sink. Because there is blood flow, portal vein, hepatic veins close by, they take the heat away, so you have a heat sink effect. So any vessels near to vessel 3 mm near the tumor will actually take the heat away. You might not have a temperature for necrosis there. So adverse effects for ablations, mortality 0.1 to 5%. This is for any ablation. Sepsis, hepatic failure, colon perforation, portal vein thrombosis. Major complication in 2.2 to 3.1. Minor in 5 to 8.8. Interperitoneal bleeding, abscess, bile duct injury, decomposition, and pads burn. Tumor seeding along the needle track is 0.5. So that's again, you do not, if not required, do not put a needle in HCC. So this is how you treat it. So you see this lesion, you do embolization, this lesion stains up really well, and then you do a RFA and burn it. Percutaneous ablation outcomes for HCC depended on tumor size, underlying degree of cirrhosis. So this is Lencini from Europe, Italy. Well compensated, so he compared when compensated cirrhotic liver, child A, 1 month 5 centimeter, one tumor less than 5 or 3 less than 3. 1 year survival was 90 to 100%. Pretty much as good as curative. 5 year, 43 to 64%. Believe the survival is not because of HCC. The survival is because the patients actually have cirrhosis. So the underlying disease is already there. Child B or recurrent disease, 30s. Improved outcomes with RFA after TACE. Then they realized that how about we combine these 2 procedures? We do TACE and RFA. So the trend which I follow and a lot majority of cases follow is to do the TACE first and then do the RFA, because you decrease the blood flow during TACE, so it causes less heat sink. And the other thing is you can stain the tumor very well. Some people feel that it is better to do the RFA first and then the embolic works better. So they do RFA first and do TACE later. So this is a big article from Peng coming from Asia actually, RFA versus TACE RFA. So they compared. This is a prospective randomized control trial where they compared RFA to TACE RFA. 2 groups, patients are divided. Some got just RFA and some got TACE RFA. Single center, RFA had 95 patients, TACE RFA 94 patients. This is what they saw. So the TACE plus RFA patients did far better in overall survival than just the RFA patients. Okay, recurrence-free survival was also longer. So it clearly points that if you combine these 2 modalities, the outcomes are much better. Then what they did was long-term outcomes comparing surgery to embolization for treatment for solitary HCC. They compared when you have a 7 centimeter tumor and the surgeon wants to go in and take it out, he can take it out. But what were the outcomes? Were they comparable to our embolization or did the patient do worse? So retrospective review of 73 patients, solitary HCC, 7 centimeters, median follow-up 10 years, no difference in overall survival occurred of 1 patient. No difference in distant intrahepatic and extrahepatic progression, more complications in the surgical group. So if you have the same survival benefit, you have same response, why would you want to do surgery which has more complications than just the embolization? So this is where surgery and embolization. This is the overall survival by initial treatment. This is overall survival by treatment methods, surgery, emboval, ablation, embo plus ablation, overall survival by Ahuja staging proportions, same. Then they came up with another article in EASL where they said cost effectiveness of hepatic resection versus percutaneous RFA for early HCC. So everything is now cost driven, right? So let's compare the surgical cost of taking out a lesion to just doing a RFA ablation. And again, what we found out is, this is coming from Europe. 17 studies, 4,000 patients, resection, and then about 4,500 RFA. They did Monte Carlo analysis, RFA lower cost and similar outcomes for single less than 2 to 3, and tumors less than 3 centimeters. They're divided into 3 groups. So as long as tumor is small, resection does not have a better outcome. has more complications, is expensive. So why would you do it? Just touching a word on sorafenib. So if you ever talk to the oncologists, they'll all talk about this study. This is a New England Journal article which came out in 2008, where they actually compared, they gave 6,002 patients, they gave this agent sorafenib versus placebo, 42 to 41%. Trial was stopped at the second interim analysis. So after the second analysis, they stopped the trial, they didn't continue it further. So the median overall survival in the sorafenib group was 10.7. They didn't get any treatment, was 7.9. So basically had a benefit about 2 months. And there was a big news that, oh, we have a drug to treat HCC now. What was the benefit? 2 months. So this is the only drug which is being used in HCC. It is to be used only, this trial, the other problem in this trial, this is one of the SHARP trial, was all these patients were ECOG 1. So now you have an ECOG 1 patient whose survival as such is good. And then they gave him sorafenib. So this is the only thing which really works. The only complication you need to remember is this medicine causes hand-foot syndrome. This is the Asia Pacific trial. 226 patients with unresectable HCC assigned to sorafenib versus placebo, 2-stage randomization. Overall survival 6.5 to 4.2, about 2 months. Median time to progression 2.8 to 1.4. Not really much significant, but if you talk to the oncologists, they really like this medicine. So what is really happening to HCC? So negative trials for HCC post-SHARP. That was 2008. Since 2008 to 2013, they've had so many trials. 1, 2, 3, 4, 5, 6. 6 failed trials for any systemic chemotherapy for HCC. In contrast, during the same period, 6 new FDA-approved drugs for RCC. So for HCC, for some reason, you really do not have a good chemotherapy. That is why all these treatments are important. Coming to some new concepts, radiation lobectomy and segmentectomy. Should be a E here. So this concept is coming where you actually treat the patient with Y90. You want to treat a whole lobe. So what they did was they gave a high dose of Y90 to that lobe, or what they did was they treated that lobe twice. So concept of radiation lobectomy. Coming from surgical, where surgery used to do a lobectomy, they just gave a high dose of Y90. Not only did they control the tumor, but they also caused the opposite lobe to hypertrophy. Segmentectomy is a new concept where they said, let's not do RFA, let's just take a small segment of the liver and give a high dose of radioembolization to that segment. It just looks like a segment of RFA. And you're doing it through an arterial process. So these are all papers here. I'll just show you. You see this big tumor here? This is known as radiation lobectomy. This whole tumor, this whole lobe, gone. And see the left lobe. This is the left lobe. See the left lobe here. Hypertrophy of the left lobe. And you're doing it only by doing radioembolization. There is no surgery here. Then there was a concept of TACE versus TACE plus SBRT. TACE is just transarterial chemoembolization. SBRT is external beam radiation for these tumors. So when I was in Portland, we used to do a lot of SBRT. We had one of the biggest groups of SBRT there, where they would actually target the tumors. The problem is, how do you target liver tumors? So to target liver tumors, you need something to label there. So we used to do transarterial chemoembolization, label with lipidol, and they would target the lipidol with external beam radiation. And we compared transarterial chemoembolization to this combined treatment and found that it was much better to combine the treatment with SBRT. We went a step ahead. We compared transarterial chemoembolization plus RFA to transarterial chemoembolization plus stereotactic body. This is what I presented at SirSpheres last year. So you see this is a TACE lipidol. You see the staining very well. This is RFA. This is actually the same patient you have on your, if you go back and look to the new requisites, the cover of the requisites, this is the image there. It's the same patient. So we did RFA of this patient. This is how we do RFA. 20-month follow-up. Perfectly treated. And then we had some patients in the dome where we could not do RFA, where we did chemoembolization and then we did SBRT. I will not take you through SBRT, how this is done, how it is planned. And they had, these are the curves. So median time to survival for RFA was better. Median time to progression for RFA was better, but did not achieve clinical significance. So guidelines by ASLD. So as per guidelines today, Y90 has been shown, this is their wording, shown to induce extensive tumor necrosis with acceptable safety profile. However, there is no studies demonstrating an impact on survival. and hence its value in clinical setting has not been established and cannot be recommended as a standard therapy for advanced HCC outside the clinical trials. And this is a level 2 evidence. TACE is recommended as first-line non-curative therapy for non-surgical patients with large multifocal HCC who do not have vascular invasion or extrahepatic disease. So this is level 1. This is coming from the ASD guidelines. So Y90 is still not in their recommendations. This is the algorithm by ASLD. You diagnose, is liver transplant candidate, goes to transplant, is a resection candidate, gets resection, you check what child PU is, TBLE, TACE if needed, RFA. If he is no, then you see child PU, see if it's a resection candidate, you kind of follow this. It is here when the lesion is more than 5 centimeters that they come into that Y90 range. So this is the new algorithm where they have Y90 here, they're recommending Y90 here, but there's still a level 2 evidence. So this is something which is really innovative, which is coming up. This is happening in Hopkins, where what they're using is they're using imageable beads. They have these 70 to 150 micron beads, but you can actually see them on angio. You can actually see those beads go into the specific areas, go into the arteries. So they're using rabbit model liver disease. So this is the rabbit liver. That's why if you see the liver, it's right on the center. You'll think that why is this liver left side is liver? The rabbits and pigs, the liver is right in the center. It's not on the right side. So they're targeting this lesion. You can actually see the beads go there, and this is the staining. You can actually see the beads go into the tumor. This is one of the new images happening. So in summary, HCC is a multimodality, multidisciplinary treatment for standard of care for HCC. Curative treatments are resection, ablation, and transplant. Local regional therapy is TACE and Y90. Systemic therapy today is sorafenib. Combination therapies are evolving. Combination means you can do TACE plus RFA, TACE plus SBRT. You can combine sorafenib with TACE. So all those combination therapies are in the work. Thank you.